Hello, my dear doctors. So, going to discuss about the Mrcp Paces 23 consultation station, and today going to talk a bit about Addison disease. And this case is also actually quite common, and there's a high chance that you may get this case in your consultation station. Okay, so let's start. So remember, the consultation station is a new station in Mrcp Paces. It's a 20-minute station where you have 15 minutes to take the thorough history, do the general physical examination, obviously the relevant physical examination, answer any if this patient has any queries, you should manage it, and there'll be 5 minutes for the examiner to ask you relevant questions about the case. Okay, so today we're going to discuss about the Addison disease. So let's talk a bit about the history. So I'll just show you some points which you should ask in the patient salient, which you could ask the patient in the if you're suspecting Addison disease. So our patient is 44-year-old man, and he presents with a 3-month history of fatigue and anorexia. Now remember, the most common causes of primary adrenal insufficiency or Addison disease is the destruction of adrenal cortex. Usually it is by an autoimmune process, it's called autoimmune adrenalitis. Isolated autoimmune adrenal insufficiency is more common in males, while it is more common for females to have multiple endocrine organ involvement. The Addison disease, the onset is usually subtle, and there is a gradual development of symptoms, and this can delay the diagnosis. Like in our patient, there is a 3-month history of fatigue and anorexia. He reports that fatigue has gradually worsened over time. So the severity of signs and symptoms, it depends on the rate of loss of adrenal function. So some patient may present with vague and non-specific symptoms. For others, primary adrenal insufficiency, it remains may undetected until a stress or they have some illness which can precipitate an adrenal crisis. The patient has also noted a 4 kg of loss of weight. So weight loss is seen mostly in patients with Addison disease, and it's mainly due to anorexia. However, we should also consider the role of dehydration. So important thing is, if the patient has told you that he has a weight loss, then malignancy should also be considered as a differential diagnosis. So metastatic cancers, they can infiltrate the adrenal gland, and it's another important cause of primary adrenal insufficiency. His wife reports that the patient color appears to have changed recently. Now, the skin pigmentation, they occurs because of the cortisol deficiency, and what happens, there is increased production of a prohormone, which then when cleaved, it produces the active hormones including ACTH and MSH. So it is MSH actually that is responsible for melanin synthesis. So in elevated levels, this MSH, it can cause increased melanin synthesis, and it leads to hyperpigmentation. The patient denies any nausea, vomiting, dizziness, any syncopal episode, or loss of consciousness. Important negatives to ask in the patient who has presented with fatigue and anorexia. So some patients, they can present with some abdominal symptoms such as nausea, vomiting, and abdominal pain. They may report diarrhea that alternates with constipation, and sometimes this is actually can mislead the clinic for an incorrect differential diagnosis, and it will delay the management. So whenever the patient has abdominal pain and vomiting, it should alert the clinician to the possibility of adrenal crisis. And cardiovascular symptoms such as dizziness and syncope, they are mainly due to volume depletion and secondary to aldosterone deficiency. And remember that the first presentation in a patient with previously undiagnosed primary adrenal insufficiency, it can be adrenal crisis. So adrenal crisis, it can present as shock and with non-specific symptoms like nausea, vomiting, fever, lethargy. Patient may have a weakness, confusion, or in the worst case scenario, a coma as well. There is no arthralgia or myalgia. This is very important negatives which you should ask the patient about any arthralgias or myalgia, because patient can report the musculoskeletal symptoms, and in some cases they may be the predominant symptoms. He is otherwise healthy. There has been no recent illness or trauma. So infections, remember, including TB, HIV, and fungal infection, they all can lead to primary adrenal insufficiency. Serious infections or acute stress, they can also precipitate an adrenal crisis. Sometimes the blunt trauma can have the potential complication of adrenal insufficiency, but it is most relevant in patients who presented with like abdominal pain, back pain, or flank pain, and usually after like motor vehicle accident. He does not take any regular medicines, and there is no significant past medical history. So remember that substantial portion of the patients, I must say about 50 to 65%, who have autoimmune adrenal insufficiency, they can have other autoimmune endocrine disorders like celiac disease or type 1 diabetes and Graves' disease. So must ask about these. If you find a hyper pigmentation and with diabetes, type 1 diabetes in the history, then you already got your diagnosis. The patient most likely has Addison disease. So he does not take any regular medicines. Medicines are important because if the patient is on anticoagulant, it's a major risk factor for adrenal hemorrhage, or it can be infections leading to adrenal crisis if they have an adrenal insufficiency. And there are some medicines which can also cause adrenal insufficiency, like some of the drugs, they inhibit the cortisol synthesis, like ketoconazole, fluconazole, and some of the drugs, they accelerate the metabolism of cholesterol, of the cortisol, and some of the examples are like phenytoin, barbiturates, and rifampicin. He lives at home with his wife and is working happily as a primary school teacher. So patients with long-standing untreated, if they got adrenal insufficiency, they may present with psychiatric symptoms. So patients or the family, they can report the symptoms consistent with like depression or psychosis. They can have mania or anxiety, others. So must ask about the social history of the patient as well. Okay, so this is all about the history. Remember to ask about the important negatives which I have mentioned here, and take a thorough history, including the medical history, past any past illnesses, or and the complete social history as well. So after you have taken the history, then you like to examine the patient. So in this patient, the patient blood pressure is 110/80 with a drop to 90/40 mg upon standing. Sometimes in the PACE station, you will ask that I like to take the blood pressure, and the examiner may say it's not necessary. Then you can ask the examiner that I like to do the check for the postural hypotension. So, and this happens because there is a deficiency of mineralocorticoid, like aldosterone in patients with primary adrenal insufficiency, and these patients can have a postural hypotension and low resting blood pressure. So the remaining vital signs are within normal range and the patient is afebrile. So the pulse you can check yourself, and other vital signs, like if you are interested, then you can ask the examiner. The patient BMI is within the normal range, so just look at the patient and you can have a fair idea that whether the patient has an ideal BMI or not. His skin is diffusely hyperpigmented with the most prominent hyperpigmentation present on his knuckles and palmar creases. So hyperpigmented skin, and you especially look for on the knuckles and on the palmar creases. And also look at the oral cavity. There will be hyperpigmentation in the oral mucosa. And the other important thing is look for any vitiligo, because it is associated with it can be a sign of an underlying autoimmune disease, and in some patients, small areas of depigmentation, usually bilateral and symmetrical, they can occur if there is primary adrenal insufficiency. So there are no areas of vitiligo, and the neck examination is unremarkable with no goiter present. So here also we're looking for any other autoimmune conditions like autoimmune thyroiditis and Graves' disease. Then you examine the abdomen. The abdomen is soft and non-tender. The remainder of the physical examination is normal, and the bedside blood finger prick test reveals a BSL of 5.5 millimole per liter. This one also you can ask the examiner, I want to check the bedside blood sugar as well. So remember that abdominal examination is important, because patients who present with adrenal crisis with primary adrenal insufficiency, they can have a generalized abdominal tenderness on deep palpation. We don't know why this happens. The exact cause is still unclear. So patient is likely to present with nausea and vomiting as well, and clinician may be thinking about some surgical causes. You may refer the patient to the surgical department for the abdominal pain. Okay, so this is the examination for the Addison disease. So mainly you will be looking for doing the abdominal examination, looking for the pigmentation, asking the examiner about any postural hypotension, or if there is blood pressure available in your time, you can check the postural hypertension yourself as well. So what will be the investigations for the Addison disease? So usually we do for check for the we expect to see low early morning serum cortisol and an elevated ACTH level. So remember, the diagnosis of adrenal insufficiency, regardless of the etiology, it requires the patient to have inappropriately low serum cortisol level. So generally the serum cortisol levels, they are highest in the early hours, 6 to 8 a.m. So if the patient has an early morning cortisol level of less than 3 microgram per deciliter or less than 80 nanomole per liter, then this suggests a diagnosis of adrenal insufficiency. What about the urinary cortisol? Well, urinary cortisol, it can also be measured, but it can be normal in patient with partial adrenal insufficiency, and therefore cannot be used as a screening tool. And the ACTH, well, it is very helpful in determining the patient whether the patient has a primary, secondary, or tertiary adrenal insufficiency. We know that ACTH actually it is produced by the anterior pituitary and is responsible for stimulating the release of cortisol from the adrenal cortex. So what happens in primary adrenal insufficiency, the ACTH level is expected to be high, as this indicates there's abnormalities at the level of the adrenal gland, and there's a lack of negative feedback to regulate the amount of ACTH produced, so thereby it causes increased production of ACTH. Suppose if the ACTH level is low, then this indicates that the pathology is either at the level of the pituitary gland or the hypothalamus. So in this situation, cortisol levels are low, and this is a reflection of reduced level of ACTH or lack of ACTH production. Okay. So other blood tests, you're going to look for serum electrolytes, and you will be expecting to see any hyponatremia and hyperkalemia. So this is a typical pattern if we have hyponatremia, hyperkalemia, and metabolic acidosis. And blood should be obtained for random cortisol level testing, and treatment should be commenced immediately. The calcium, magnesium, and phosphate levels are all within the normal range. Important to check for the calcium and for the phosphate and magnesium. So one of the main function of aldosterone is to increase the urinary potassium excretion. Therefore, when there is hypoaldosteronism, there is decreased excretion of potassium and causes hyperkalemia. Rarely we may see hypercalcemia, and this is usually associated with acute renal insufficiency. Hematological testing shows a mild anemia and eosinophilia. So you may see anemia and eosinophilia in Addison disease, and if there is a eosinophilia, it suggests adrenal insufficiency in the right context, and normocytic anemia, they can be seen in some cases. ACTH stimulation test is performed, which confirms the diagnosis of primary adrenal insufficiency in this patient. So briefly about the ACTH stimulation test, it's also called, other name is synectin test, and it can be performed using either a high or low dose synthetic ACTH. And the principle of this test is to assess the cortisol level in response to stimulation with ACTH. So if the patient has an intact pituitary adrenal axis, the serum cortisol level should rise within 30 to 60 minutes in response to the ACTH. So a positive test where there is an absent or inappropriately low plasma cortisol response alongside with the elevated renin and elevated ACTH is required. It is required for the diagnosis of primary adrenal insufficiency. So following this, a CT scan of the abdomen is performed, which is largely unremarkable, and no further imaging studies are deemed necessary. So a CT scan is actually useful in narrowing down the list of the potential etiologies of primary adrenal insufficiency. Suppose if you see the enlarged or calcified adrenal gland on CT, then it can suggest either the patient has malignancy or maybe infection or hemorrhagic causes. So these findings actually can be helpful in excluding the autoimmune adrenal insufficiency as a cause. But remember that the CT scan can be normal in tuberculosis, so we cannot exclude tuberculosis. So obviously we need further testing like chest X-ray and AFB and PCR and microbacterial culture if we suspecting the active TB in high-risk population especially. So further scans such as PET scan, it can be performed in instances where malignancy is expected, and this reduces the need for more invasive measures like CT, guided needle aspiration of the adrenal gland. And the patient is tested for 21 hydroxylase antibodies, which returns a positive result. 21 hydroxylase antibodies, these can be performed to investigate clinical suspicion of primary adrenal insufficiency and where no other clear cause is evident. And these antibodies are actually directed against an enzyme and is required for production of cortisol. So it's important to investigate for any other autoimmune conditions and endocrine pathologies in the patient. So these are all about the investigations which should be done and what to expect in case of Addison disease. Now coming to the management, and I have already discussed in my previous presentation, especially in the consultation session, it's always wise to divide the management into the immediate management, short-term management, and long-term management. So this patient is presenting with chronic adrenal insufficiency. It's not complicated yet by adrenal crisis. So no immediate steps are required actually in this situation. What about the short-term management? A discussion is held with the patient and his family history about the new diagnosis of Addison disease. Remember, the patient education is vital in the management of Addison disease. There should be a thorough understanding of the disease, and it includes the explanation of the hormone deficiency. We should emphasize upon the importance of adherence to replacement therapy and what could be the consequences of non-compliance. He is informed about the need for commencing medications. So remember, this primary adrenal insufficiency, it requires lifelong treatment with glucocorticoid replacement. And the aim of the treatment is actually to mimic the pattern of natural cortisol synthesis by the adrenal glands. So usually patients start on the low dose possible to relieve symptoms. The patient is started on oral hydrocortisone 12 mg in the morning and 8 mg in the afternoon, and is also commenced on fludrocortisone 100 microgram orally daily. So hydrocortisone is commonly used in the management of adrenal insufficiency. Remember that prednisolone, it can cause growth suppression, so it will be avoided in children. And in adults, particularly if there are concerns about adherence, prednisolone can be used for maintenance therapy because prednisolone has a longer duration of action and it can be given as a once daily dose. What about dexamethasone, which is another long-acting glucocorticoid, but it's not commonly used for replacement therapy because the dosing can be difficult to predict and the patient may be overtreated. So best is to start the patient on the hydrocortisone. Twice daily dosing is recommended starting regime for the most adults. As we know, there are adverse effects associated with glucocorticoid administration in the evening. Dose should be done in the morning and mid-afternoon. Adjustment to the dose should be done slowly, and we should increase it slowly in small increments. And it is important that when the patients are unwell or are undergoing any procedures or surgery, the glucocorticoid dose is adjusted accordingly to reflect the normal increase in secretion of cortisol in our body. This is actually vital actually to prevent an adrenal crisis. So mineralocorticoids, well, they are generally eventually required for maintaining the normal blood pressure in patients with adrenal insufficiency. So it aims to maintain the normal level of plasma sodium, potassium, and renin concentration. Remember that unlike glucocorticoids, the dose of mineralocorticoids does not need to be adjusted acutely when there is an acute illness or stress. But in some cases, if the patient has excessive sweating in warm weather, then or there is increasing loss of salt in perspiration, may be an indication for a dose increase. A sick day management plan is also established together with the patient and his family, and they're also informed of the modification of glucocorticoid dose during minor illness. So, in the event of minor illness, patient can self-increase the dose of glucocorticoids, and the recommendations are variable, but in general the dose can be increased by 2 to 3 times the usual dose. However, um, caution should be taken if a patient is suffering from nausea or vomiting, because the absorption of the oral replacement may be compromised. So, the patients who are planned for elective surgery, pre-op consultation should be carried out and to create a modified dosing plan for this glucocorticoid replacement therapy. And remember that the additional dose is variable and depends on the level of stress which is expected to be induced by the surgery, like patient going for minor surgery or major surgery. So generally, patient they should be able to resume their usual maintenance replacement dose on day 2 or 3 post-operatively. So this is about the short-term treatment. What about the long-term treatment? The patient is scheduled for a DEXA scan. Long-term treatment with glucocorticoids carries its own set of risks. One of the most predominant side effects is that of lowering the bone mineral density and of osteoporosis. So this patient requires a baseline measurement of BMD and assessment of fracture risk at the time of diagnosis. So following this, the BMD actually should be assessed every 2 years, and if there is a notable reduction in the BMD, then adjustment of glucocorticoid therapy may be required. And it is also, I think, advisable to revisit the possibility of other endocrine conditions like thyroid disease or celiac disease. One should be aware that other side effects of glucocorticoid therapy is diabetes, weight gain, bruising, and thinning of the skin. A follow-up clinic appointment is organized in the outpatient department to review results and monitor his response to replacement therapy. Treatment actually should be led by a specialist clinic with ongoing monitoring. So once the patient is stable on the treatment regime, the frequency of follow-up clinic appointment it can be reduced to once a year. Ongoing monitoring is important for other autoimmune disease like type 1 diabetes, and we can use the labs as a screening tool for these patients. His progress is assessed and patient is reviewed for any complications. So some patients they remain symptomatic despite the glucocorticoid mineralocorticoid therapy. Although not routinely, it's not routinely recommended, but some patient may benefit from like androgen replacement therapy with dehydroepiandrosterone, and there has been some benefits of DHEA replacement because it improves the general well-being in a patient. They can improve their sexual function in women, increase the bone density and lean body mass. So the efficacy of the treatment it can be objectively measured using serum sodium, potassium, and renin concentration measurement at clinic visits. And our aim is to maintain the plasma renal in the upper to normal range, and which will obviously indicate the optimal mineralocorticoid replacement. So I think we have discussed almost all the salient points in the Addison disease. As I mentioned in my previous presentation also, just go through the resource which you are reading, and I will see you in my next presentation. So we'll continue with our presentations of the consultation station. Thank you very much.